Of all the side effects that might occur with sorafenib, which include, of course, the hand-foot syndrome reaction, add to the fatigue and the diarrhea, a little bit less common the hypertension, probably more rarely bleeding. Over here, this patient ended up with grade 1 hand-foot syndrome and grade 1 hypertension. Should not really be discouraging in any way. These are expected side effects and definitely very manageable. If anything, for the hand-foot syndrome, there's a lot of data in the literature already. Probably for grade 1, I will probably make sure that the patient is supported with local measures, i.e. some creaming, probably kind of, keep them warm at night with maybe covered with some cotton gloves and maybe cotton socks for the feet. Make sure that probably a visit to podiatrist before starting on therapy, ensure that all the skin is healed. No, there's no hyperkeratosis that's really left over because these are a little bit harder to heal per se. And if anything, you just kind of ensure that the patient is in contact with the physician at all times and make sure that there's an update about how the skin is doing. There's no necessity at all to change the dosage or even to stop it. Obviously, if the side effects are a little bit more intense, i.e. the hand-foot syndrome is at grade 2 or 3, then obviously there is a certain management approach for that purpose. On first event for grade 2, pretty much we can let it go and just continue with the supportive measures. On a second occasion, probably it would require some holding of the therapy. Same like for a grade 3, holding the therapy and probably dose reduction. The good news about sorafenib is that it has really a very wide margin of activity, i.e. it can work at different doses. And it's important that the physician and the patient do recognize that it's not like, for example, if a patient develops hand-foot syndrome only 400 milligrams twice a day, that's the end of the story. Actually, we can go to a lower dose of half the dose. We can go even to the quarter of the dose. We can go even lower than that. And as such, there's really an important message over here to ensure that the patient and the physician are in close communication, and at the same time, the symptoms are managed and the dose is adjusted accordingly, but not to give up on it until really we know that for sure that is not working well for the patient. The hypertension, by all means, it can happen. And if anything here, a calcium channel blocker is a classic antihypertensive that can be used in that setting. And again, close monitoring of the blood pressure while on therapy should not really even restrict or reduce the dosage of the treatment. If a dose reduction is necessary for sorafenib, there are a lot of mechanisms of doing it, and these are reported in the literature. If anything, a 400 milligram twice a day, which is a standard dose, can be reduced to 400 milligram daily. And if a patient is on 400 milligram daily, the package insert says 400 every other day, but you can consider also 200 milligram daily. And we have seen situations where you can even go lower than that, even to 200 milligram every other day or 200 milligram every third day. These mainly are dose reductions and management that are due either to side effects or toxicity, and sometimes even because of the limitation of the liver function, i.e. with the Charles-Pugh scoring.